Welcome back to the Collidescope series, where we discuss rare cases in renal pathology that have two diseases that collide or meet in one patient. I'm Dr. Charles, and I'm joined today by our fellow in training, Dr. Frank Boyd. Frank, how are you doing today?
I'm doing well. How are you doing?
I am great. Today I have an interesting case that demonstrates that even with small/suboptimal renal biopsies, we can reach a diagnosis.
Awesome. What do we have?
So the patient is an 80-year-old male who presents with acute kidney injury, serum creatinine 6.4 milligram per deciliter. The patient was found on the ground after a fall. Creatine kinase was elevated at 10K on admission. The patient also had elevated LDH, low hemoglobin, low haptoglobin, and schistocytes on peripheral blood smear.
What does the biopsy show in light microscopy?
So on light microscopic evaluation on low power, here we could see two tissue fragments that are predominantly composed of medulla. We can't really see any glomeruli on low power. So right off the bat, we know we're dealing with a suboptimal biopsy. So here on higher power, we can see there are no glomeruli present. We just see a piece of medulla that has scattered tubulointerstitial inflammation. And on even higher power, we can see several scattered tubular casts. Frank, how would you describe these tubular casts?
They look eosinophilic, granular, somewhat beaded. Do you have a PAS stain of the casts?
Yes, so here we see a PAS stain.
Yeah, so these casts do not show features associated with light chain cast nephropathy, such as cellular reaction, fractioning. They do not appear hard or very PAS pale.
Exactly. And by immunofluorescence, kappa is equal to lambda within these tubular casts, which excludes a light chain cast nephropathy. So here we could see that there's some acute tubular injury with some cytoplasmic thinning. And then on higher power, we could see some interstitial edema with this blue material spreading apart tubules.
That would correlate clinically with the patient's presentation of acute kidney injury. Were immunohistochemical stains for myoglobin or hemoglobin ordered in the case?
So here we could see myoglobin stain, and we could see a couple beaded tubular casts that are positive.
In the clinical history, you said the patient was found down, presumably from a fall, and had an elevated CK level on admission. So this patient likely has a component of rhabdomyolysis from the fall.
Correct.
So moving on to the pathophysiology behind this injury, myoglobin is directly toxic to the kidney, particularly to the renal tubular epithelial cells, and is a central mediator of acute kidney injury and rhabdo. Myoglobin released from damaged muscle is freely filtered by the glomerulus and accumulates in the renal tubules, where it exerts toxicity through several mechanisms. Myoglobin induces oxidative injury via its heme moiety, generating reactive oxygen species and free radicals that damage tubular cells, especially in acidic urine. It also precipitates with Tam-Horsfall protein, forming obstructive casts in the distal tubules, and promotes renal vasoconstriction through lipid peroxidation and the generation of vasoconstrictive mediators such as F2 isoprostanes. These processes result in direct cytotoxicity, tubular obstruction, ischemia, and inflammation, all contributing to AKI.
That was a great explanation. In addition to myoglobin staining, a hemoglobin stain was also performed and showed a couple positive scattered tubular casts as well.
Oh, wow. So we have both myoglobin cast nephropathy and hemoglobin cast nephropathy.
Exactly. The patient's labs, including elevated LDH, low haptoglobin, low hemoglobin, and schistocytes on peripheral smear, suggested an underlying hemolytic anemia. A retrospective review performed at Arcana Labs by Z et al. Of 27 cases with hemoglobin cast nephropathy showed 30% had an autoimmune hemolytic anemia, and 26% were drug-induced. All biopsies showed findings similar to ours, including acute tubular injury and pigmented proteinaceous casts. The mean serum creatinine on presentation was high, around 8 milligrams per deciliter, which lowered to 1.3 milligrams per deciliter after 9 months, with 78% of patients returning to normal kidney function. So thank you guys for tuning in for another episode of Collidescope, and we'll see you all next time.